Hello, everybody. Thank you all for being here on this rainy day, unfortunately. But it's always fun to come and see a lot of familiar faces and meet a lot of new ones, and just all the vendors, everyone that's here. It's such a wonderful opportunity, so glad that you all could be here. It's our privilege to be able to present a small breakout session, and I'd like to keep this as interactive as we can, especially toward the end. We'll save a lot of time for questions. Our topic, as you can see, is the forgotten half. The practice where I am right now, Memory and Movement Charlotte, we spend a lot of time focusing on the needs of the caregivers, of the family members, and the people who need support, who need education, who just need some guidance as to what do I need to be doing. So we'll talk a lot about that. So it's my privilege to be here to talk a little bit about what we're doing, and also my privilege to be here talking with the other forgotten half, as we just said, Robyn Wolkofsky. She's a physician assistant in our practice and very much involved in the caregiver support. So next slide, please. So the main objective today, we'll talk a little bit about epidemiology of caregiving. We'll also talk about some sort of mind-blowing, staggering statistics related to what we call Caregiver Syndrome and what that impact can be on the mental and physical health of the caregivers. And then finally, Robyn is going to talk to us a lot about strategies, how to empower yourselves as caregivers, and also a program that she helped start that we call Take Charge. Next slide, please. So we talk about caregivers, we much prefer the term care partners. Unfortunately, in all the literature and with all the programs that exist right now, caregivers is the term that's being used, so we sort of went with that, although we very much believe care partners is a better term because that's essentially what's happening. They're people who are family members, they're loved ones, they're friends who are really very much partnering in the care of the patients, and they partner with us as the healthcare providers on how we can better meet the needs of the families. But the term sort of informal caregiver is what we refer to as unpaid members of the family. Usually these are husbands, wives, children, family friends who are providing free services, free care for people suffering from whether it's neurologic disease or other diseases, and they're very much unpaid. We see that the impact of this is enormous. When you look at the dollars that are at play, when you think about hiring caregivers, professional caregivers that we're paying an average of $25 to even $35 an hour for caregiving services, that money really adds up. To the tune of, when we recognize that there are currently 53 million unpaid or informal caregivers in America, that adds up to what would approximately be about $500 billion. Staggering. So again, the services that are provided are huge. We talk about the average duration of being a caregiver or a care partner. It's about 4 years, but about a quarter of caregivers are in their role for more than 5 years. And we talk about the sandwich generation. More than half of caregivers are what we call sandwich, meaning they're taking care of elderly parents or elderly friends, whatever it may be, while also trying to raise their own children and figure out their own career path. And so you can imagine the stressors that are at play here, trying to do a good job in what are 3 really distinct roles. Next slide, please. So caregiver syndrome is actually the term that has been recommended and encouraged to be used by the American Medical Association for very particular reasons. We used to talk about burnout. We used to talk about stress. But when we talk about caregiver syndrome and actually recognize it as a potentially medical condition, it sort of forces healthcare providers to recognize caregiver syndrome as a big risk factor for a lot of different health problems. So primary care providers who recognize that one of their patients is a caregiver it behooves them to keep a very close eye on their cardiovascular health, on their mental health. And so using the term caregiver syndrome has sort of developed some credence around what we all need to be focusing on. A lot of folks will talk about feeling alone, feeling unsupported, unappreciated. Those are some of the themes that we hear. Of the 53 million American caregivers, the unpaid, the informal ones that we talk about, you can see the statistics. 40% feel emotionally strained, 20% financially are strained because not only are they taking care of a loved one free of charge, so to speak, but that's time that they can't spend at work or trying to bring in some money in some way. Perhaps the services they're trying to bring in, whether it's paid caregivers or other therapies, are out of pocket. So when you think about, we all try to save for retirement and what that's going to look like, and sometimes what we save for, is traveling and fun things. We don't take into account what if we have to come up with a lot of money to pay for different services, so the financial strain is real. And then finally, the physical strain, we talk about different health problems that can pop up and what happens, and there's so much stress and so much anxiety around it. What do I need to be doing? What do I need to be thinking about? So much emphasis placed on the individual who has Alzheimer's, Parkinson's, whatever it may be. There's less emphasis on the caregiver and what are my health issues and should I go to the doctor and maybe I'm delaying my visits. So I think it's important to consider those things. The signs and symptoms of caregiver syndrome: feeling depressed, feeling anxious, feeling isolated. We see a lot of folks who say they feel like they're losing control of their life, they feel more irritable, they're not sleeping. A lot of folks come in and they feel so guilty because they're either getting more impatient or they're developing resentment or even anger toward their loved one. I was speaking to a family that I've been working with for a few years, and the wife, who was sort of the caregiver, if you will, she said to me, I finally have now become the caregiver. I'm no longer the wife. And that was a big revelation to me, that this is kind of where she is. And I said, well, now is the time that we need to be putting resources around you so they can be the caregivers and you can get back to being the wife, and find enjoyable activities that you're doing together. You're not having to do X, Y, or Z. You're not having to take care of all the bathroom duties. You're not having to take care of all those things that make you feel like you're not his wife anymore. And that also tells me that we need to be thinking about these things a lot sooner, before she feels that way. And so that was enlightening for me to hear. And so I think being more proactive, not only for caregivers to identify, okay, here are some risks of what could happen if I become the sole caregiver and I lose my identity, but also as healthcare providers, I think it behooves us to spend time with family members to understand how do we help them preserve their identity and their primary role, which is not to be a caregiver. Next slide, please. So here's some eye-opening statistics, including for me. I've focused so much on how people are walking and moving and tremors. For most of my career, it's not necessarily been focused on caregivers. And I think in my new practice, I've learned a lot from my partners, especially Robyn. And you see these statistics, and when you see that 14% of the caregivers are saying that they report 14 or more mentally unhealthy days in just the last month. Almost 18% will say they've had 14 or more physically unhealthy days in the last month. That tells you a lot. Almost 40% are not getting enough sleep. We hear that all the time when you're looking at your budget and thinking about, do I need someone to come in for a few hours during the day so I can get to the grocery store, so I can get to my doctor's visits, so I can get some exercise or do something healthy for myself? That's often the discussion, but the place where a lot of folks will try to save some money, understandably, is at nighttime. Do we really need someone at night? And if someone's waking up 3-4 times a night, if there's a lot of anxiety and behaviors at night that are disruptive and the caregivers aren't getting sleep, it's hard for them to be the best versions of themselves during the day to take care of their loved one. This statistic really caught my eye, that 45% of caregivers will neglect their own health to the degree where they're actually developing chronic medical conditions such as diabetes, stroke, heart disease, and this leads to the fact that there's a 63% higher mortality rate in caregivers compared to the age-matched controls who were not caregivers, so their own friends and family members who were not caregivers. There's a 63% higher mortality rate, and then when you break that out, 70% of caregivers who are over age 70 will die first. And that brings up a whole other discussion, and I think a lot of, what do we need to be doing to put together the right resources? And, I'll just tell you, personally, my parents are in the same situation. My dad is the caregiver. He's now 80. This statistic really caught my eye. It says, okay, we need to be thinking about what are we going to do to take care of mom if something happens to dad. And these are the conversations that we all need to be having with the providers that you're seeing. And I think what I've learned so much from Robyn and our team is this is where sometimes the more important work is being done. And so with that, I'd like to introduce my partner, Robyn Wolkofsky. She's a PA. And I'll let you tell a little bit about your background, but thank you for being willing to talk about Take Charge. And next slide.
Thank you all for coming to our breakout today. We're really excited to see so many people here, and we really appreciate it. Coming to a lecture like this is just an opportunity for you to take charge. It's kind of the philosophy we teach, but even just showing up at a symposium on a rainy Saturday when you're tired and the week was long, that just shows how much love and dedication you have to caring about yourself or the patient or your loved one. So about 12 years ago or so, my grandmother was descending into kind of advanced vascular dementia. We knew none of it though. She was in Florida, and we were called down in crisis and disasters, and the doctors didn't know our names. We never received a call. Her partner was not willing to talk openly to protect them, and it was the opposite of everything that we felt there's got to be something. So after a visit down there and seeing what was going on and being in healthcare, on the way home, I just took out a notebook and started writing about what I wish that was in place. And over the year, Dr. Edwards created this clinic based on family support and education in order to take better care of our patients. And Take Charge is kind of the culmination. We were able to, with a grant, put this program in place last year. But these are things that everybody can take pieces of, and that's what we hope today, is to tell you what we find is helpful. And if there's one or two things that work for you all, then we've done our part. So the idea behind Take Charge in the philosophy is that we know we can't fix these illnesses. They're not cured illnesses, but we can empower the patients and their loved ones with more of a sense of control and prepare for what might be coming, and also have plans in place and pivot when needed. But that can help make the journey easier and offer more connection, and we hope lower stress to prevent all the health crises that Dr. Iyer was talking about. So really we're talking about education first. Knowledge is power, and our clinic has gained a lot of knowledge over the last decade, but also in caring for their own friends and family. And we learn most of what we know from our patients and caregivers. And so now we're here to kind of disseminate it. It's practical, but if you don't know about the disease and what's going on in the brain, it really is hard to understand some of the behaviors and struggles that you have at home. And so that leads to a lot of frustration, discord in the home. If we can understand and teach you a little more about the actual process that is going on in someone's body, it helps to kind of take some of the emotion out of it and let us understand it and make a plan. Also, what to expect. I have a lot of caregivers who are coming in and saying, I need to know what's coming. I'm a planner. My stress at night, I'm wondering what's coming in the next 2 years, 5 years, 10 minutes. So really just being able to share with you all some, we have no crystal balls, but being able to tell you what we see throughout the stages, and also some things that can be thought through, like the crisis planning, should we need it, can really help kind of lower those what ifs and get back to the present. Crises are sometimes preventable, and we do a lot of safety discussion, because when someone has a traumatic fall, for instance, or a major medication error or an accident on the road, those can create a major decline that otherwise could have been prevented. Not always, but some. And so every major trauma or decline is really harder for someone to come back from. And so as opposed to more of a gradual course, we may see a steeper drop. And so we're trying to intervene sooner, prevent these things that make life that much harder. And then strategies, that's probably the major thing that people call with. We have wonderful nurses who are here to educate when things are starting to stress, and we see every morning something's going on. The tension home is unbearable. We've kind of got to dig further and see what is the root cause and what strategies maybe can we teach to help you guys cope. Another piece beyond education is support, and that's important not just for the caregiver or for the patients, but for the caregivers. And we know things like the Parkinson's Association, the Alzheimer's Association have wonderful support groups. But oftentimes there are other things that are holding people back from going to them, and we need to kind of figure out the root cause, maybe bringing individual counseling in, maybe connection between the loved ones themselves. Sometimes important conversations are kind of kept out of the room because they're a bit scary to talk about. In that sense, that becomes a sense of an elephant in the room and a little more disconnect. And I feel like this is one of the biggest things that families go through in their lives, and to be able to kind of come closer and feel like we're on the same page can reduce a lot of friction and fear. And so we try to open up the conversation. And also connecting you to your medical team, teaching you how to advocate, when to call, how to know what's a change that might be related to the disease, or at least knowing who to ask if you don't know. And just feeling like there's another source of support from you on the clinical side. So we really try to provide that. Then I want to go through just a few other concrete tools that we use at Memory and Movement. There's a lot of caregiver stress techniques, and those were discussed beautifully this morning, so I'm not going to go through kind of the management of in-the-moment stress, but more some tools that can be implemented. First is open and honest and frank discussions about where we are. Everyone's thinking about it in their head, but not many people are talking about it out loud. And so whether it's having a name for a diagnosis that may be harder to hear, or understanding what stage we're at, we find that if people want to know more, that's why we take the time that we do to really get that out in the open. And the words don't change what's actually going on. The words just kind of take this big, heavy weight and just put it out there so we can start dealing with it. So we have time alone with the patient and with the caregiver at every appointment. The appointments are a bit extended for that reason, but that is really where we get some more critical information and allow people also to be able to talk about things that they might not want to say in front of their loved one, whether that's on the patient side or the caregiver side. But it often lets us get to the root of an issue. As I said, we have a lot of education. Our doctors are incredibly educated as far as strategies go. Really, it's amazing the amount of time it'll take to pivot from the medical side to the support side. And we also have a host of advanced practice providers like myself and nurse navigators who really are kind of the cornerstone of the advice for our families. There's a meeting called a care plan that most people don't know exists, but Medicare pays if somebody has any cognitive impairment, from memory loss to hallucinations to dementia, alongside any other disease. Could be someone with Parkinson's who has some memory impairment. Medicare enables you to have a care plan meeting, and in our clinic we do this. It's an hour meeting with most of the times the caregivers, so they can kind of talk through issues that they haven't been able to without the patient there, but a lot of times we encourage, especially when patients want to be involved and early in the disease process, that everybody comes and we can get a lot talked about together. But our social worker and myself, or one of my colleagues, we go through everything from questions about the diagnosis. We want to know the main concerns of the moment. We want to know everyone's goal. That's something that people are like, I've never thought about that. Am I allowed to have a goal for this situation? We talked through advanced directive planning. Safety, we have 7 main safety issues with resources and strategies. How to identify which ones we're at risk for now and which ones should we keep an eye out for. Hooking up with resources in the community and that kind of thing. We also hone in on caregiver stress and support. So it's a tool that we print out in a document, and you have it kind of as a bit of a guide over the next year. We can do it every year, but we send it to your primary doctor. We encourage you to bring it if you go to the cardiologist next week or an emergency room next month. If the medical team is not aware of the big picture home situation and how impactful all the recommendations can be, it really sometimes can lead to a less realistic plan. And every medical provider wants to understand the big picture, so here's a tool for you to help, we can help you communicate that to them. Crisis plan has evolved out of these crises where we get a call on a Monday morning that our caregiver went in the hospital on Saturday night and dad's home alone and no one knows what medications he's on and he's anxious and mom is freaking out in the hospital. The kids are in California. And this happens a lot. And so we have kind of distilled this down into a worksheet, but really anyone can take a plan and say, short term, in 48 hours, if I needed to be gone, what are we gonna do? If I need to be gone for 2 weeks, 2 months, or on a longer term basis. And we really encourage you to sit down with someone you trust and banter it about and making plans. And they might not be the perfect plan, but they're the best one we can come up with today. And if the best plan is I don't have friends or family that can step in, but here's a home agency that I've called, I know the phone number, the director's name, and I know they can call on the spot, they can come immediately, then that enables the caregivers to go to sleep at night with a little bit less of a weight of what would happen if something happened to me tomorrow. And that's a really big worry for a lot of our caregivers, and I feel like that's one of the things that leads to the constant stress that leads to the health issues for our caregivers that Dr. Iyer was talking about. So if we can chip away and create a crisis plan, maybe that's one way we can lower the stress just a little bit. Another tool that we have is a handout for education like this carbidopa-levodopa adjustment handout. We feel like the knowledge that we have is not secret knowledge that we want you to have to wait 3 months to come back and get. And if you're having a problem at home, we want people who are on carbidopa-levodopa, which is many Parkinson's patients, to understand the nuances of the medicine. And if you have the knowledge, we know there are safe ways that adjustments can be made between visits, or at least give you the terminology that you can call us and give us what we would need to help you adjust your medicines. So this is just another way that we really want to empower. It's not see you in 3 months and let us know if anything happens at that time. We really want to help you work with your body and your meds between those visits. We have a take charge binder, and there's one on the back table, but everybody should have some kind of Boulder Notebook file. Basically, it's what we created to kind of keep these tools in one spot, but also that if Aunt Sue from out of town is visiting and you're trying to work and manage things or just need a day, Aunt Sue can take Dad to the memory and movement center, grab the white notebook and go. You're going to the cardiologist, everything's in the white notebook. But so it's just more of a symbol of having a little bit of organization around walking out to a stressful visit. We have a red medicine bag also, throw the bottles in the bag, we always want to see them. There's so many unintentional errors that can happen between our providers, to fax machines, to pharmacies, to patients with old bottles laying around, so we always want to see the actual bottles that you're using. So we created a bag, just throw them in. And then we have some online tools that we want you all to have access to, whether your patient's in our clinic or not, it doesn't matter. We have an online library that with a grant we were able to compose. It's called Take Charge, and it has every real bit of education information we have learned, presented, and distilled down into handouts and small videos, whether it's 2 minutes, 40 minutes. We talk about everything from how to manage hallucinations and delusions, to end of life, to brain health for people who just want to stay sharp. So we really encourage you to have the information at your fingertips, so you can kind of take some control and look at what you're interested in or what is applying to your loved one. And then some virtual and in-person opportunities. We really are aiming to expand those over the next couple of years to connect, because we know how important that is, and there are wonderful support groups in the community. So sometimes those are what needs to be expanded, but oftentimes there are niches that we haven't been able to pinpoint. such as a younger onset group of patients. We have the Parkinson's who really need a different kind of support and different activities that really lend themselves to an after-work atmosphere, for example, or their loved ones whose family members are in long-term care, and that's a whole different set of concerns that they'd like to discuss with people in similar situations. So we're trying to constantly tailor things and bring whatever we can to you all. During the pandemic, Dr. Iyer and I did a happy hour online every Thursday where we just kind of all saw each other's faces, dressed and grabbed a non-alcoholic beverage to cheers each other online, just to connect. But those are the things that can help, we hope, people feel less alone. So anyway, I just want to thank you, and those are some of the tools we help patients take charge with, and you're definitely not forgotten. In our eyes, you're a critical part of this equation. So we're here for any questions.
Since I joined the practice 3 years ago, and sort of brought the Parkinson's side to the business, if you will, and had joined what was then known as the Memory Center, Charlotte, they've always been doing these visits that are sort of split, where half the time is with the caregivers and half the time is with the patient. A lot of my patients don't necessarily need that. They're very cognitively intact, and they may or may not even have what they consider a caregiver. So as I've learned kind of the best way to sort of transition into this practice, we've had a few bumps in the road where maybe people do need a little more of that level of support, and we just haven't quite gotten to that situation. So I think if there's ever a concern, just call and let them know that, hey, I need some time with the team separate, or when you get there, just let them know I'd like a little bit of time today, and we can certainly do that.
Such an amazing question. I wish everybody was thinking that way and that we could kind of figure this out together. And what I'll say from the caregiver's side is what I see often, and every situation is different. I won't speak for anybody. But at the beginnings of an illness like these, sometimes people are kind of hiding things because they don't want their loved one to be looked at any different, and the loved one is asking them to keep things private. And then there's never kind of this day when all of a sudden you need support and the lights go off and we can now say, well, for the last 7 years we've been dealing. And people take the hint also, the people around them. So they want to respect their privacy, keep dignity, not invade privacy. And so everyone's trying to do the right thing, but what kind of happens is it becomes this unspoken thing, and the burden on the caregiver becomes higher and higher. So as somebody outside, we encourage people to talk to their loved ones early about things and allow them to come closer. Not everyone feels comfortable doing that, but as a friend or family, putting out the offer and saying whether it's written, a nice written note puts people, I think, on their own terms, but allowing people to know that, I've noticed over time some things are changing, or, I'm not in the position, but I just want you to know that I am here, and I'd really like to help in any way, whether it's emotional or walk through this journey with you guys. You're not alone. Just words like that can really open the door and allow them to tell as much or as little as they're ready to. But we want to erase the whole stigma, and like if somebody had, God forbid, a stroke, a heart attack, or cancer treatment, and there's people running on casseroles, as Dr. Edwards likes to say it, and this is very, very different. And so we really teach people to, be loud, be proud, and allow your friends to get to come closer, because it's also a gift for them. I mean, I tell people all the time, how many times have you been there for other people in your life? It is a rewarding gift. That's kind of what this is all about, this whole life. So if they allow to give that gift to some others, it really can be, closer connection. Thank you for that.
Yeah, it's a very simple question. It can open a lot of doors, and it's, how are you doing? I'll sometimes ask that question, and also wow, and the thing that takes a
Everything comes
turn, and how are you doing, and recognizing, I have other friends, I have family members who are taking care of a loved one, and I see the toll it can take. How are you doing? Have you had time to get to your doctor's visits? Have you had time to get some exercise? Are you doing all those things where you can really be the best version of yourself, so you can provide the care? And back to the story I told earlier, she wants to continue being his wife, not the caregiver. How do you feel like your role is? And I think those are ways that you can probably come at it. I think it's not very often where people will ask me here, well, how are you doing?
I can always say I went to the Symposium and they said stuff that I haven't heard before, so I just want to see if it's relatable. Yeah. Pass them on our website too, so feel free to look under kind of travel strategies. But we really try to look at kind of what's coming up and match it with what the struggles are of the family, and then see how we can simplify. Sometimes it's starting to, instead of tackling a cruise first, it's a night in the mountains, and we kind of test out the waters a little bit with some strategies we put in place, which can help reduce the anxiety about something bigger. There are also often resources wherever you're going to hook up with, knowing who a local urgent care is, a local doctor, pharmacy. There can be ways to do that. Sometimes people take someone with them and ask someone to accompany them. It's kind of a right-hand man, and that can be amazing. So, we kind of tweak it, but finding ways to kind of simplify it, reduce the expectations that this trip is going to be exactly like the last one. We still want to get there. If the goal is get there, then that can help a lot. There's some other small, more detailed things we can talk about, but it's kind of how we approach it, because we do want to bring, enjoyment and joy and connection into your world.
And so most of that data comes from two sources. I mean, one was from the American Caregiver Alliance, and the other is from the Alzheimer's Association. And so, again, the data around, 4 years is the average duration for a caregiver comes a lot from that. The definition of when it begins was really varied. It's from the time where they actually had to either quit their job to be at home and do that, or ranging all the way from the time where they suddenly had to start organizing their medications and taking care of certain tasks that the other person used to do. So it really ranges. That's a great question, but I can send you the data if you'd be interested in looking at it. Yes.
Those groups might be, I think what he's asking about is, how did he get so short? Is it longer? What?
It can be an average of
But just having all the statistics.
Yeah. And also in another situation where maybe they stop being a caregiver not because their loved one died, but because they brought in 24/7 care, or they went into assisted living, so they were no longer the caregiver. So a lot of that when does it begin and end?
And also, a lot of people have an illness that they recover from that has a beginning and an end. So that could have included people who caregave for a period of cancer treatments, and then people were in remission and independent again. So that it's going to kind of be on the higher end for the patients no longer more chronic progressive illnesses that we see. They go as longer in those cases.
I thought I saw a few hands somewhere over in the back, but
I think we're getting ready for lunch.
lunchtime. Well, thank you very much. We'll be available during the break.